Jacob. I'm a final year medical student at Lancaster Medical School. Welcome to part 2 of this gastroenterology series where we're going to be talking about ascites. So with that being said, let's get straight into it. So let's talk about some definitions, as we always do first. So we know that ascites is an accumulation of serous fluid within the peritoneum. And serous fluid is kind of a pale yellow, watery fluid found between within two membranes within the body. So some examples are within the peritoneal cavity, that would be classed as ascites. You can have fluid within the pericardial cavity. That could represent a pericardial effusion or a pleural effusion, for example. So fluid within the pleural, within that pleural space, and typically between the membranes of the parietal, the outer membrane, and the visceral layer, the inner membrane. And for ascites to be detectable, there has to be a minimum of 1,500 mLs, and this is kind of on examination, for example. And it's less in tall, slimmer patients. But we have ultrasound essentially, and that's very useful at picking up volumes much less than 1,500 mLs. And ultrasound is therefore the first line investigation following your history and examination. The grading assumes that there aren't any complications. So grade 1 is mild and only detected by ultrasound. Grade 2 is moderate, causing symmetrical abdominal distension. Grade 3 is severe, causing marked abdominal distension. And then we have to think about a term called refractory ascites. It might be refractory to the management plan, what you've implemented. For example, the diuretic therapy. So we have diuretic resistant ascites, which is resistant to sodium restriction and intensive diuretic treatment for 1 week. We're going to learn more about the types of diuretics what are used, such as spironolactone, and an intensive diuretic treatment could suggest that you've used, in addition to spironolactone, also something like furosemide. So you're using two types of diuretics. And then we have diuretic intractable. So this is due to the development of diuretic-induced complications that prevent the use of an effective diuretic dose. So this is more related to the complications of the diuretic used, which limit the most appropriate dose being used. Okay. This is quite an important concept, what we need to understand, and this is known as the serum ascites albumin gradient, otherwise known as SAAG. So essentially, how you calculate SAAG, it's the concentration of albumin within the serum minus the concentration of albumin within the fluid within the peritoneal cavity. So you can work out the concentration of albumin in the serum via liver function testing. And then you can also work out the concentration of albumin within the peritoneal cavity within the fluid by doing a diagnostic paracentesis. And essentially this gradient helps us to determine the underlying cause of the ascites. So when we have a gradient of greater than 11 grams per litre, we can be quite certain that the underlying cause is due to portal hypertension, resulting in a hydrostatic pressure imbalance. So essentially, increased pressure within that splanchnic circulation, forcing fluid from the vessels to within the peritoneal cavity. And then we can then further classify this into looking into the concentration of total protein within the ascitic fluid. And when the protein's less than 25 grams per litre, this suggests that the hepatic sinusoids are scarred. And when the ascitic protein is greater than 25 grams per litre, this suggests that the sinusoids are intact. So examples of where the sinusoids are scarred is seen in a problem such as cirrhosis, If it's late Budd-Chiari syndrome and where a patient has massive liver metastases. Where the acidic protein is greater than 25 grams per litre, like I said, that's where the hepatic sinusoids are intact. So this can be seen in conditions such as congestive heart failure or constrictive pericarditis, where we have that systemic venous congestion, seen earlier in Budd-Chiari syndrome. Can also be seen in IVC obstruction and sinusoidal obstruction syndrome. So when we have a SAAG gradient of less than 11 grams per litre, the underlying etiology can be quite broad, so there's a lot of different things what can cause this. But this is typically where we have an oncotic pressure imbalance because we have a less albumin within the serum, typically, especially in things like nephrotic syndrome when we have albumin loss in the urine. Therefore, fluid from the peritoneal cavity can't return to the blood vessels, so you have a buildup of fluid in that within that space. So let's look at some of the different causes. So one can be biliary leak, typically caused by trauma, surgery, or malignancy. And when we do our peritoneal fluid analysis, or acidic fluid analysis, the colour can tell us a lot about the underlying problem. So if we had a biliary leak, the colour of the acidic fluid might be a dark brown colour. And then we have things such as nephrotic syndrome, where albumin's lost in the urine, kwashiorkor, which relates to nutritional albumin deficiency, pancreatitis, where we have leakage of pancreatic enzymes into the peritoneal cavity. These enzymes digest the tissue and cause peritoneal inflammation and increased vascular permeability. So sometimes in cases the vessels could be more permeable. And we have bowel obstruction, peritoneal carcinomatosis. So that's where lymphatic channels are blocked and there's increased vascular permeability. So peritoneal carcinomatosis typically results from a primary cancer where you have metastases within on the peritoneum causing the problem. And then we have lymphoma, where there's an obstruction of retroperitoneal lymph vessels, which can lead to the accumulation of chyle, and this results in something called chylous ascites. And then it can also result due to tuberculosis, where we have peritoneal tubercles. There's essentially from these tubercles a production of protein-rich fluid, and this happens within the peritoneal cavity. So let's talk about the pathophysiology of ascites. So we can have hepatocyte, liver cell dysfunction, reduced albumin synthesis, decreased capillary oncotic pressure, resulting in the hydrostatic pressure is greater than the oncotic pressure within the systemic circulation. Therefore, you have extravasation, movement of the plasma into that peritoneal cavity, leading to fluid accumulation. And it's quite important that the main mechanism associated with the formation of ascites is related to portal hypertension. Low albumin can contribute and exacerbate ascites in cirrhosis, though. So we have portal hypertension. This is our main mechanism. So increased pressure within that hepatic circulation, increased hydrostatic pressure within the abdominal capillaries. Fluid moves from the plasma in the capillaries into the peritoneal cavity, and essentially it's resulting in this in the same end result. And we can also have nitric oxide entering the systemic circulation because of the increased pressure. The kidneys detect a lower effective arterial blood volume, so they retain water and sodium. And again, it's going to result in the hydrostatic pressure being greater than the oncotic pressure in the blood, and therefore movement of the plasma into the peritoneal cavity. And then we're going to end up with ascites. So there's features such as shift in dullness, and these are examination features, positive fluid thrill, and bulging flanks, particularly when the patient's in a supine position or lying on their back. Here we have a nice picture of some ascites. Okay. And then This here, we can also essentially, because we've got fluid moving from the plasma into the peritoneal cavity, we're going to have a lower circulating blood volume, hence a drop in blood pressure, and this can further be detected by the kidney, so it's going to essentially exacerbate this process, and it's going to keep going in this cycle. Okay. Reduced blood pressure also stimulates ADH, antidiuretic hormone secretion. So essentially that's going to make the collecting ducts more permeable to water. There's going to be more free water reabsorbed relative to sodium, and this can cause something called the dilutional hyponatremia. So this is something you can also be aware of. Symptoms of ascites. So we have abdominal distension, weight gain, or weight gain because of that retained fluid, general discomfort, nausea and appetite suppression, typically because of the abdominal distension. And patients might also report increasing shortness of breath, and that can result and the reason why that happens is because I think if you had lots of a raised intra-abdominal pressure, because if there's retained fluid, there's going to be increased pressure on the vena cava and the diaphragm, and this is going to result in a reduced venous return. Pressure on the diaphragm can make it difficult to breathe also. If it can't, if the diaphragm, if the hemidiaphragms can't flatten during inspiration. Okay, let's talk about some of the signs of ascites, what you might pick up on physical examination. So remember, we do inspection first. Okay, so you want to inspect the patient's abdomen when they're standing up and also lying down. And like I mentioned before, when the patient's lying down, the flanks might be full, and when they stand, this is going to cause an accumulation of the fluid in the lower abdomen. And patients can also present with umbilical hernias or inguinal hernias because of the increased intra-abdominal pressure. You might also want to be aware of some of the stigmata, peripheral stigmata of liver disease, which I've mentioned in the previous video, such as hand signs, jaundice, gynecomastia, etc. Okay, and then it's important to also check for other abdominal features. Sometimes in peritoneal carcinomatosis, we can have a Sister Mary Joseph nodule. This is essentially a metastatic tumor, and that can present around the on the umbilicus. And also when you're doing, because it's a systems examination, you want to examine for lymph nodes. And remember the left supraclavicular node, if that's enlarged, that could suggest an underlying gastric malignancy. Okay. And then don't forget your palpation either. On auscultation, you might be able to hear Crevelier-Baumgarten sign. Remember that's a venous hum within the para-umbilical veins, which in cirrhosis sometimes become recanalized. Okay, and then special tests. We have shifting dullness and fluid thrill. So essentially, in shifting dullness, what you want to do is you want to percuss from the level of the umbilicus to the area of the suspected fluid, and initially, when you percuss, the sound of when you percuss should go from resonant to dull. So it should go dull to when you reach the area where you suspect that the fluid is. You can then ask the patient to roll onto the other side and then re-percuss, and then the area which was dull will now sound resonant. And that's essentially how you do it. Fluid thrill, sometimes this requires two examiners, or you can ask the patient to place their hand on the midline of their abdomen and press down. And then essentially what the examiner does, they place one hand where they suspect the fluid is, and then they can essentially pulse on the abdomen, and their other hand is placed on the other side of the abdomen, and essentially their other hand should be able to feel the fluid pulsing to that side. So going from the initial side to the other side of the abdomen. Okay, and that can sometimes be done by two doctors or one doctor and the patient might assist. Um, okay, and that's all testing for that fluid within the peritoneal cavity. Okay, so here we can see that the flank's full and the patient is in a supine position. Remember that caput medusae sign, what we sometimes have in cirrhosis. And then we can see in this diagram here, the patient's actually using their arm and placing it along the midline of their abdomen. And sometimes the doctor might, flick the finger on one side and then try to feel for the fluid impulse on the other, or they might press. It's probably done in various ways depending on the clinician. Okay, so let's talk about some investigations in terms of bloods and imaging. So bloods, we could do a full blood count, coagulation screen, because coagulopathy and thrombocytopenia are signs of advanced liver disease. LFTs, we need to do our serum albumin for our SAAG gradient. Use and ease, because we can sometimes in decompensated liver failure, we might have acute kidney injury. And so there might be an elevated creatinine. That's something we want to be aware of. And then because of the effects of ADH, essentially, we can have a hypervolemic, hypotonic hyponatremia. So the hyponatremia is the most important part of that. Okay, and then in terms of imaging, first line is the abdominal ultrasound. Fluid appears as either hypo or anechoic, black, essentially. And then internal echoes, so areas of white essentially suggest debris, and there might also be some features of the underlying cause. When you're using the ultrasound, in terms of the anatomy, there might be an accumulation of fluid in the hepatorenal recess, otherwise known as Morrison's pouch, or the splenorenal recess. We also have a CT abdomen, and this might be indicated in situations such as malignancy or secondary peritonitis. Secondary peritonitis is different to spontaneous bacterial peritonitis. So spontaneous bacterial peritonitis typically results due to cirrhosis. Secondary peritonitis would occur, for example, secondary to hollow viscous perforation, such as small bowel perforation. And we maybe have free, but viewing from the CT, we'd have some free intraperitoneal fluid, and the density depends on the type of ascites. Okay, so when we're talking about ascites investigations, patients have something called a diagnostic paracentesis, which is where they collect a sample of the ascitic fluid for analysis. And there's various parameters what we can look at to try and determine the underlying cause. Okay, and this is for all patients with new onset ascites to determine, like I said, the underlying cause, or patients at risk of developing spontaneous bacterial peritonitis. So we can look at the gross appearance. If it's kind of transparent to yellow, this is normal. If it's cloudy, this could suggest infection or malignancy. Bloody could suggest trauma or malignancy again. If it's milky, this could be chylous ascites, which could be again related to cancer. For example, where you have compression of the lymphatic ducts. And I've already mentioned that if it's dark brown, this could suggest that there's a biliary leak. We look at the cell count. So if the neutrophils are greater than 250 cells per millimeter cubed, this could suggest that there's spontaneous bacterial peritonitis, which we're going to talk about in future videos. And then we can look at we've already talked about this in quite a lot of detail. So the SAAG gradient, if it's greater than 11 grams per litre, this suggests that there's portal hypertension. If it's less, then there could be an alternative underlying cause. We're going to look at the ascitic fluid albumin. Remember I said you do that, you can find out that value from the diagnostic paracentesis for the SAAG calculation. And then we can look at the ascitic fluid total protein. This can be used to differentiate between hepatic and cardiac causes, because remember, when we're thinking about the integrity of the sinusoids within the liver, are they scarred or not? And then it can also be used to differentiate between spontaneous bacterial peritonitis and secondary peritonitis. Um, and the total fluid protein in SBP is less than 10 grams per litre. And then in secondary peritonitis, it tends to be greater than 10 grams per litre. SPP, when we have spontaneous bacterial peritonitis, we have a single bacterium translocating, so moving into the acidic fluid. And like I've mentioned already, secondary peritonitis follows hollow viscous perforation. Additional testing, what you could consider for suspected infection, you could do a gram staining culture. Suspected malignancy, you can consider cytology and tumor markers. CA125 tends to be raised quite a lot of the time. That's something to be aware of. If you suspected chylous ascites, within the fluid, the triglyceride levels might be raised. And then if you're thinking more towards pancreatic ascites or ascites as a result of bowel perforation, you may have an elevated acidic fluid amylase. Okay, so let's talk about the management of ascites. So generally, you want to treat the underlying condition and offer therapeutic paracentesis for tense ascites. Okay. So essentially, the management is made up of these factors. So we want to reduce the dietary sodium. We restrict sodium to reduce portal venous pressure and reduce fluid retention. Because remember, water and sodium they go everywhere together, fluid and sodium. So we want to try and reduce that dietary sodium intake to roughly 2 grams per day. We can also fluid restrict the patient to 1 litre per day if the sodium is less than 125 milli equivalents per litre. We also have a potassium-sparing diuretic, which is spironolactone. We can also add a loop diuretic if the patient doesn't respond, if they're in a hospital setting or they need a fast resolution. Okay, if the patient has a tense abdomen, you can offer therapeutic, so not diagnostic, this is therapeutic abdominal paracentesis. Some of the indications is tense/large ascites, refractory ascites where it can be repeated every 2 weeks, in malignancy-related ascites, or potentially where diuretic therapy is contraindicated. It's ultrasound guided. It requires albumin cover during or immediately post-procedure. And the reason for that is you can sometimes have post-paracentesis circulatory dysfunction, because if you're removing the fluid within the peritoneal cavity, you can potentially alter the circulating volume because you're going to be removing them plasma proteins. And then we also want to think about preventative antibiotics such as ciprofloxacin or norfloxacin for patients with cirrhosis and with an acidic protein of 15 grams per litre or less. Okay, so we'll talk a little bit more about therapeutic paracentesis. So we'll talk about some landmarks first. So we can use essentially a needle to drain that acidic fluid from the peritoneal cavity. And sites can be at the midline, so 2 centimeters below the umbilicus, or 5 centimeters cephalic and medial to the anterior superior iliac spine, which is illustrated by this diagram here. When we have large volume ascites, so lots of fluid what needs to be drained, the patient is supine on the back with the head of the bed slightly elevated. And when we have a smaller volumes, the patient is on their side in the lateral decubitus position. And when I'm using this term tense ascites, it means when there's pressure on the abdominal vessels. So we want to relieve that pressure. And when they're doing therapeutic paracentesis, they might use a Z tracking technique. So prior to needle insertion, they're going to pull the skin where the entry site is 2 centimeters caudal or inferior, and they don't release the skin until the needle's removed. This helps to form a seal, preventing fluid leakage from the needle insertion site. Okay, so let's talk about the management of refractory ascites. Okay, so this is when the ascites doesn't respond to treatment or recurs after therapeutic paracentesis, despite sodium restriction and high dose diuretic therapy. So that's just a reminder of that definition. So we want to optimize the medications and ensure that they're having that sodium restriction. We want to repeat the therapeutic paracentesis, plus remembering to offer that IV albumin because we don't want the post-circulatory dysfunction. And then other surgical options, what we might look at is transjugular intrahepatic portosystemic shunting. So this is essentially a method to try and reduce the pressure within that portal system by creating connections between the branches of the portal veins and the hepatic vein. So we're improving that circulation, and some clinicians may even consider a liver transplant. Okay, and this diagram illustrates the TIPS surgery. Okay, so let's talk about the complications of ascites. So related to liver function, we have reduced bile salt formation and decreased complement formation. Bile salts normally have some antibacterial activity, therefore if they're being produced less, we're going to have reduced antibacterial activity. In terms of complement formation, there's less, therefore there's going to be less membrane attack complexes formed. So we're going to have this innate immune system dysfunction. We also have portal hypertension contributing to the complications too. So we're going to have a backup of less oxygenated blood into the splanchnic, into the gut circulation. So there's reduced oxygen to the intestines, therefore reduced peristalsis and increased transit time. So the GI contents are going to be stagnant, and then all of these factors are going to contribute to bacterial overgrowth within the intestines. And these bacteria can translocate into the ascitic fluid. And there's two ways in which they can do this. So they can migrate transmurally, so they migrate directly across the intestinal walls to seek out the nutrient-rich ascitic fluid, or they can migrate via the blood, which is what hematogenous spread means. So the bacteria move from the gut into the systemic circulation. And because of the liver dysfunction, the liver's reticuloendothelial system cannot clear the bacteria, allowing them to migrate into the ascitic fluid. And then other complications, which I've mentioned in the previous cirrhosis video, as such, related to ascites, hepatorenal syndrome, and also hyponatremia, which are related to portal hypertension, remember. Okay, and then as a result of either of these two processes, we have spontaneous bacterial peritonitis, which I'll reiterate is where we have an ascitic fluid neutrophil count of greater, remember neutrophils are granulocytes, a granulocyte cell count greater than 250 cells per millimeter cubed. Just to wrap up the video, we can talk about the monitoring of ascites. So we can either do serial measurements of abdominal girth or serial measurements of weight. And recent changes in weight are much more likely to be due to water loss or gain rather than changes in fat or lean muscle mass amount. Okay, so that draws the video to a close. Thank you very much for watching. Remember to like, subscribe, leave a comment, and stay tuned for our next video where we're going to be talking about spontaneous bacterial peritonitis. All right, take care, and I'll see you in the next video.